we made that notice before open enrollment for Medicare Advantage, because most of the United insured folks in our 3-county area are with a Medicare Advantage plan, with the hopes that people would make a different decision during that open enrollment. We contract with almost every other MA plan that wants to contract in our 3-county area. We have contracts with Cigna, HealthNet, Humana, Moda, Pacific Source, Providence, and Regents, and we have our own health plan as well. And I will just say here that I have heard, some cynics say that we terminated our contract with United just to build up our own health plan, and I can assure you that that's not the case. We gave everyone information about seeking health insurance outside of our health plan and encouraged people to look at all options out there. We have wonderful partnerships with all those other health plans that I mentioned, but I know there has been a transition there, and that is unfortunate. I guess the last thing how am I doing on time, Karen? Can I have a few more minutes, or am I done?
No, take a few more minutes.
Okay. I think, one other thing I was asked to speak to is just what can we do to support local healthcare? And I think there's a lot of different things that we can do, and I won't go into all of it right now. I'm sure it'll come up organically through the rest of the questions and conversations. But one of the things that just absolutely keeps me up at night right now is that in healthcare, especially hospitals, we have gone through 4 really, really tough years. I can't describe how tough they've been. Dealing with the pandemic, the fear around the virus and getting the virus, having the right PPE, the list goes on and on. And then over the last year, it hasn't been so much COVID, but it's been, we've been short-staffed. We've been really busy, not so much COVID, but all other kinds of sicknesses. So we've been trying to do more with less. And the morale of the organization, and frankly, in healthcare in general, is suffering right now. My heart goes out to our frontline workers, our nurses, and our doctors, because it continues to be a difficult time. Unfortunately, what we are seeing is just more and more a lack of respect to our nurses and our doctors and our frontline workers. We're seeing an increase in workplace violence. When I round in our hospitals and talk to our nurses, I always ask them about safety issues. And historically, that's been talking about patient safety issues. And now it seems like more and more the safety issues are patients that are hitting a nurse, or spitting on a nurse, or yelling at a nurse inappropriately. And I think it's tragic. It's hard for me to watch and hear that. I can assure you that everybody at Samaritan is mission-minded and there to serve our community and do the best that we can do to keep people healthy. Now, I will say that's not every patient. We have lots of good people in these communities and lots of good patients. But we are seeing more and more of kind of this angry, hostile patient that's just really, really unfortunate. The other thing I think is just engaged with Samaritan is how you can help. We are going to be doing some growth. We're going to be growing primary care. We're going to be growing behavioral health, and we're going to be growing inpatient beds at Good Sam. And, that's probably going to take some regulatory approvals to do some of that. It's going to take some fundraising to do some of that. It's going to take community engagement and support to do some of that. And I just ask for you, watch for those developments and get engaged however you would like to. We'd love to have you be part of that. And I think, Karen, with that, I will pause and turn it over for others. Thank you.
Very good. Thanks. So put your questions into the chat, and then when all 3 speakers have made their presentations, we'll start sharing those questions and getting them answered for you. So our next speaker is Angel Harris. Angel, turn it over to you to introduce yourself and talk about this from the nursing and patient perspective.
Good evening, everyone. So can you hear me okay? All right, good. Yeah, my neighbor
Sí,
couldn't
escucho
get
bien.
in.
Yo por lo menos escucho bien.
What was that? I don't know. My neighbor couldn't get into the meeting, so here she is next to me. So if you want to invite your neighbor over too, she's only a couple doors down. So, yes, I'm Angel Harris. I have been in Corvallis community for, this September will be my 29th year. Came here in 1995 to attend Oregon State University. Became a registered nurse in 2001 with my bachelor's in nursing, and then I got my master's degree in 2023. And I am a nurse educator at Bushnell University in Eugene. I worked at Good Samaritan Hospital from 2001 till 2010. And so maybe you saw me there back then. And then I went over to where I really wanted to be, and why I went to nursing school was long-term care, which was at the Mennonite home. And I worked in the rehab unit was mostly where I worked. Yeah, it was great to have that long-term care experience as well as that acute care experience. So just to give you a little background, we all are talking from our own kind of lived experiences and what we've seen. And so I'm not obviously only a nurse, but I'm also a wife of one and a mother of three, a daughter, right? A sister. And so I really am honored to be here with y'all today because I'm just thinking about my fellow panelists, Doug and Bruce, Dr. Bruce, and how we, at the end of the day, we all like experience our healthcare system, right? Not our job titles, but the fact that we are people who have kids and people who are patients ourselves, right? All three of us are patients ourselves. And so we experience the healthcare system, not with our job titles, but as people. And so I really appreciate them being here and all of our different perspectives. So I really just honor them in that. And so I did type up some stuff because if you know me, you know I'm long-winded. You got this, right? So I'm looking at the clock right now. I've got 10 minutes and I'm still just going to say I have 10 minutes. The introduction didn't count. How about that? All right, 7:26. So our health, it's interesting because our healthcare system has been failing for as long as I've been born, and that's only been 47 years. And I know, of course, before that, right? Decades and decades before that, the healthcare system, I'm not even sure when the healthcare system was working, right, for everyone. And so when I said the healthcare system has always failed, there are certain populations that we know of who have never had, especially people that look like me, we've never had a good experiences necessarily with our healthcare system. But I also know plenty of folks, and you do too, and some of you are in this room who've never, right? Who were in other populations who were white, who didn't experience very good, have good experiences in our healthcare system, right? And I think what we're seeing right now is only getting worse. And I see that more and more people are experiencing difficulties, right? Even just accessing healthcare. We talk about health insurance, but I even think about the people who don't even get to step foot inside of a healthcare facility. They don't even get the opportunity or the privilege, right? So I just want to share some of the experiences that I've had. And again, because I'm long-winded, I'm going to read some of it. So I was born in Mississippi. And if any of you know about Mississippi, I call it third world, right? And that is right here in the United States. And it has some of the worst health outcomes in our country. And I wonder how it compares to other countries, actually. I was born there in 1976 in a hospital that does not exist anymore. And I'm kind of glad it doesn't exist because they weren't able to give good care, right? And I will leave it at that. And so when we talk about, again, about the healthcare system, some of us was born into a healthcare system that was pretty negligent at best, I guess I would say. And again, so I will keep saying, and I told Mike this as well. I said, this is nothing new. This has always been. It's just that some of us didn't experience it at its worst until now. And some of us some populations have experienced it their whole lives. right? I will not get emotional here, people. So again, I was born in a state with a high number of health inequities and still is. Poor health outcomes was the name of the game, especially if you were not white and you didn't have a lot of money. Health inequities related to access and use of healthcare contribute to these disparities in health. According to the CDC, social determinants are the conditions in which people are born, grow, work, live, and age. And a wider set of forces and systems shape these conditions or daily conditions of our life. These forces and systems include economic policies, development agendas, social norms, social policies, racism, climate change, and political systems. And of course, there are so many others. I often tell people when we talk about access to healthcare is the angel that you see, the angel with the master's degree, the angel that gets to own a home, the angel that, all these different things. I don't, has access to education, access to healthcare, maybe a different angel only because of the place that she lived. Only for the fact that I don't live in Mississippi, the access to water. Remember in Jackson, Mississippi, where a lot of my family lives, remember in the summer, we talked about the fact that they didn't have access to drinking water. Could you imagine? A whole city of people, which is what, about 80% of those folks are Black people, right? And so social determinants really determine who gets access to healthcare, which is interesting because with social determinants, it's nothing related to your health, right? It's not because I was smoking that I developed lung cancer, right? It wasn't because I did something wrong. It was all because of where I grew up, what language I spoke, what color skin I had, right? What I was able to afford, right? And so keep those things in mind when we talk about what can we do to change things, right? So as a wife of one and a mother of three, I have seen and felt the barriers and failures to even get a simple appointment scheduled in a reasonable time. Can anyone relate to that? Has anyone had to wait 6 months for their knee surgery to be scheduled? That's my mom at this time. 6 months. Yes. Can you imagine the pain, hip surgeries, right? The pain that has caused, right? And Dr. Bruce will talk to you about the perspective of a doctor because I never blame them. I never blame the doctors, right? We are talking about a system that is broken, a system, not just one entity, but many together working together, and it's broken, right? So so I am grateful that I have providers that are committed to patient-centered care. But how much longer can these amazing providers stay in a failing system? As a nurse for over 20 years, I have watched patients toil and worry about how they are going to afford the treatments they need. One patient struggled as I sat in his hospital room, wondering how he would pay for an IV, y'all, that is going to help his infection. He was really considering not getting the medicine because he couldn't afford it. But if he didn't get the medicine, he may die, right? I've watched an elderly gentleman who worked his entire life, almost in tears as he realized that he needed more care and could no longer stay in his home and could not afford the cost of the assisted living facility and would need state assistance. So this poor guy had worked all of his life and could not understand why he had to empty his bank account so that he could qualify for state assistance so he could live in an assisted living facility. So instead of him worried about the changes that were happening in his life, the very real health changes, he was having to worry about money and how he was going to get cared for. How many people can afford a health insurance where the average cost is about $500 if you're lucky for an individual, or $2,300 or maybe $2,700, depending on who you are, a month for a family? Those are real numbers. Just talked to my husband about our health insurance, right? Think about that, $2,300 a month for insurance that you may or may not use. A month, people. How many people can afford deductibles of $60 just to see a provider? My son saw that bill when we went to doctor once. He thought it was a joke because we were just going to see the doctor. They hadn't diagnosed. They hadn't done any treatments yet. That was just so I can go see the doctor. And I'm happy to say that now my not deductible, what's it called? Copay. It's a copay, $60. I wish the deductible was $60. $60 copay, and now it's down to $10. But that's a privilege for us, right? To have a $10 copay. Who can afford a $60 copay, y'all? If I have a hospital stay for 3 days, I could be looking at a bill of $30,000, depending on what kind of treatment I'm getting. $30,000 for 3 days. And I'm being conservative in a lot of places, right? Why does someone needing, and I'm talking about my dad, why does someone needing their gallbladder removed get punished? Why are we punished for being sick? I became a nurse because I wanted to care and be a part of the healing of those who are sick. I'm looking at the time, Karen. I truly believe that healthcare is a right we should all have. Unfortunately, it has become a privilege, or maybe it has always been a privilege. I feel privileged to have a primary care physician. I shouldn't feel privileged, y'all, to have a primary care physician. That should be a given. And when I talk to people who are looking for a primary care physician, it's hard to find one because they are so they have so many patients already. They can't take anymore, right? So again, I don't blame the doctors. I blame the system that is allowing us not to have access, right, to the doctors because there's not enough of them, right? And before I get off, I'm not going to read the rest of this, and maybe it'll come up later. But I left bedside nursing in 2019, March of 2019. So maybe I foresaw something a year before COVID hit March of 2020. I always tell myself that, right? And I left bedside because I cried so much. You know, you cry so much because of what you see. I'm sure Dr. Bruce and Mike can understand this, can sympathize with this. And Deidre, who's a nurse practitioner. You go home and you sign up for a job to care for people.
Yeah,
and with short staffing, and with things being more about money, sometimes you don't get to care for people, right? And I didn't know what I could do. I didn't know if there was something I could do to change things, because the reason why I came again is to care for people and to help in their healing, to assist in their healing. And so I left in 2019, and I became very active in the community as president of the NAACP here in the community. And I saw, using my nursing skills, I saw how I could change some stuff. How not only myself as an individual, but getting together with people like Mid-Valley healthcare advocates, how we can change the system through policies, right? Through even how the education that we know about how do we get access to certain things in healthcare, right? So educating ourselves, educating others, helping other people understand what is the route to even have a primary care physician, because some people don't know that, right? What does the health department do? And so when I found that out, I also found out about preventative care, because I was in a medical model. And that's what I learned in school, was the medical model. And I got to learn about preventative care, y'all, and upstream, like Doug was talking about, upstream solutions, not just downstream, not just waiting till people got sick. So now I get to do, as a racial equity consultant, I get to talk about inequities and how we can address social determinants of health. And I get to talk to my students and better prepare those students in my population health and community health nursing class to address the whole person, right? To address the whole person and those social determinants, and how we, as not just one person, y'all, but as not just organizations, but as teams, to change things. And I've seen change happen, right? And so I want to leave with this. Our healthcare system being broken is not a new thing, but it is getting worse. And I'm so glad that we are talking about it, but I also want us to do something about it. There are things we can do, and I want us to start doing those things. So I'm going to now turn this over to my colleague, Dr. Bruce. Thank you guys so much.
Thank you, Angel. I think your last comments were just brilliant. We need to talk more and more about what we can do to solve the problems. And I've seen some of the questions coming through open that conversation. So the next speaker, Dr. Bruce Thomson. Bruce?
So I yield my time to Angel and Doug. I am so honored to be on this panel with you two. I really appreciate it. So I have some notes that I want to go through with you. I want to confirm some of the things that Doug has talked about, and as well as Angel has brought to this discussion. Some of this will begin to sound like a little bit of a broken record. It's just from my perspective. So I've moved to Corvallis in 1972. So except for 7 years up in Portland, I've been 45 years in Corvallis, I guess. And it was, I came to Corvallis to go to graduate school at OSU, and I found a part-time job working in the old Good Samaritan hospital laboratory at night, running chemistries for them. That helped fund my tuition at OSU. After doing research for about 10 years and in ecological research, I decided that I wanted to fulfill a promise that I made to myself and reapply to medical school. I first applied when I was number 13 in the first lottery draft for Vietnam in 1970. I didn't get in despite interviews at Albert Einstein and Columbia and Johns Hopkins. There was just too many applicants, 10,000 to 1, because medicine was the only reason why young men such as myself would avoid going to war in Vietnam. So I went up to OHSU for my medical school and residency, and I returned to Corvallis to work at Corvallis Family Medicine in 1993. It was just 10 years ago that I retired from my clinical practice of medicine at Corvallis Family Medicine after 30 years in the medical field. This evening, I'm going to talk about the primary reason for my retirement, the feelings of burnout. And this will, I think, relate to what Angel has talked about and what Doug has talked about. Much of my joy in tending to patients' needs was being replaced by the dread of meeting insurance companies' needs. I found myself having to see fewer patients and having to spend more time completing daily tasks, such as playing computer or phone tag with insurance companies and filing authorizations for my patients' needs. This is not something we learned in medical school or in residency. This was a change in the way medicine was being administered. In addition to these hours in the office, I was spending 3 hours after dinner completing documentation for the insurance companies. On most days, my lunch hour was spent doing the same thing. As far as I can recall, the situation, as far as I can tell, the situation has only gotten worse for today's medical providers. Unfortunately, we do not have the time for me to detail some of the insurance idiocies that encroached on my time with patients. Some of them would make you laugh, and some of them would make you cry. A 2014 study found that the yearly cost per primary care provider in an office of our size, 6 providers, the cost of fulfilling insurance company requests in 2014, fulfilling these requests from insurance companies was about $60,000 per provider. So for our practice of 6, that's quite a bit of money. So in 2014, I retired from clinical practice, but I continued my job as county health officer, which reminds me to publicly recognize and thank our community medical providers, including all healthcare workers who volunteered in Benton County's pandemic response. This thanks goes out to OSU, Samaritan Health, the Corvallis Clinic, and many of you participating in this meeting this evening. Together, we were among the top counties in the state with the lowest per capita death rate and the highest per capita vaccination rate. We couldn't have done it without you. But I digress. While in 2014, I felt burnout, there is now a wider recognition that burnout is a symptom of something much larger called moral injury. If you search moral injury on the internet, you will find links to the NIH, to the New York Times, to the Commonwealth Fund, to the VA's National Center for PTSD, to the British Medical Journal, and to many others. Moral injury is more than just feeling overworked. After all medical providers are highly resilient and come to medicine as a calling, not as a career path. Burnout is a symptom of an increasingly complex web of providers' highly conflicted allegiances to self, to patients, to employers, to prescribing medications that patients cannot afford, to inequities in accessing healthcare, to delays in obtaining authorization, in short, to our broken healthcare system. These conflicted allegiances cause deep soul wounds that pierce a person's identity, sense of morality, and relationships to society. In my opinion, the increasing privatization and profiteering in healthcare in the United States is not heading us in the direction that is beneficial to meet our society's needs. And in addition, there is good evidence that it plays a role in moral injury and leads to workforce shortages. So some of what Doug described as happening at our local hospital is most likely a result of moral injury. I feel compassion and admiration for all healthcare workers who continue attending to patients' needs in today's environment, and I honor people like Angel, who teaches and instructs and educates young people into how to become a effective healthcare provider. I now realize that I am still recovering from moral injury. Following retirement, I joined Mid-Valley Healthcare Advocates and started advocating for healthcare reform in Oregon, as well as at the national level. I invite you to join us. We need your help. Increasingly, Oregon is having to MacGyver ways around the challenges of providing health care for all people in Oregon. Thank you for attending. And now onward for the questions.
Thank you so much, Bruce. Oh, wow. We've had just 3 tremendous presentations. So I'll turn it to Holly now to read the
So,
first question that's been submitted.
okay, there's been several, and Doug has actually answered some of them that have already been submitted, but I would, since there were several on the same topic, Doug, I might ask you to say a few words about the letter that people received about the Belong Health ACO, because that one seems to be a little bit of a common topic. Would you mind answering that one?
Yes, happy to. And really, I don't have a ton of detail on it, but I'll just say from a high level, this is something that CMS Medicare is reaching out to provider systems like ourselves to see if those folks that are getting original Medicare, and they still would get original Medicare. This is not joining a Medicare Advantage plan or anything like that, but it is about, can Medicare work with the local clinic or system to provide some coordinated care services, wraparound services, and preventive services to test to see if we do that, can that keep people healthier and lower the cost of Medicare? So it is just something that's directly happening between Samaritan and Medicare. There's no intermediary, there's no insurance plan. It's not signing up for an Advantage plan or managed care. It still is original Medicare. It's just more of a pilot program for CMS that they've asked us to do. And frankly, we think if we can get focused upstream, there's a lot of benefit to do that. But I will say no one is required to do it. It's available. People can opt out of it.
I think just for myself, I think I've received several calls as well. People worried, I think on the heels of open enrollment and a lot of changes, maybe a follow-up letter or something, people are confused. I'm starting to see that.
Yeah,
So
I agree. I'm hearing
thank
that
you.
too. Yeah, thank you, Holly.
Okay, so there's another question. Is the AMA which limits, is it the AMA which limits the number of doctors? Either Doug or either one of you could answer. All 3 of you or somebody from our board.
Yeah, Mike is more qualified to talk to it than me. Go ahead, Mike.
It's more rumor that the doctors in the leadership of the AMA want to protect their salaries and find ways to limit production of doctors, and that's rumor. But I do know that the leadership of the AMA has focused on specialty care because most of the decision makers are specialists, and they underpay and underemphasize the importance of primary care. I'm sure they're capable of limiting production or education of doctors, but I don't have proof of that.
Thank you. Let me see, I'm scrolling through.
I'll just add to that, Holly.
Okay, great.
I agree with what Mike said. I think also what I'm seeing now is what's preventing more doctors is not even necessarily medical school spots, it's residency training opportunities. And I am happy to say it here within our 3-county area, we have the 2nd largest residency training program just behind OHSU. So we have about 110 residents in our system that are doing everything from family medicine to internal medicine to general surgery, orthopedic surgery, psychiatry. These are all some areas where specifically psychiatry and primary care areas where we need more access. We need more doctors, and it does help to have that residency program so you can bring doctors in, train them, and hopefully they like the community and stay.
Okay. So there's people on and this one is for probably Mark or Mike actually, because people want to know what we could do to fix this situation in any of the speakers. It's like, okay, let me see. I'm trying to blend, merge some questions. What's happening with the Oregon movement for our own single payer plan? Maybe somebody could give a quick update on that. Mike, Mark.
I yield to Mark or Bruce.
Or Bruce, yeah, any of you. Karen, Legislative Committee.
I'll give my quick answer to that. We are waiting to see what the governor does in announcing a 9-member governing board for a new healthcare system for Oregon. The voters voted to put healthcare into the Constitution. The Senate and legislature passed a bill, Senate Bill 1089, to create a governing board. There was a task force that created a model plan that is actually a pretty good plan, and we're hoping that they'll use that or use many elements of it. But what this turns out to look like is going to depend a great deal on who the governor appoints to this governing board. This is my opinion now. Others may give a different opinion, and I think we ought to include Warren George in this conversation, as well as Bruce and whoever would like to speak to it. But there's a lot of nervousness for me in this as we wait to see who will actually be working this system.
People are asking, concrete steps that individuals can take. So anything that they can do, people on this Zoom, that they can take to help move this along.
Well, if you're interested in legislation, which is we have a legislative committee, so there's always room for people to work within the legislative committee. If you're interested in learning more and spreading the word to your family and friends, we have an outreach committee. And the outreach committee was responsible for gathering us together today, and will be involved in future town hall meetings. So there's two areas right off the top of my head. Following what your legislators are doing up in Salem is another way if you're that interested in legislation. We're coming up on a year for the short session, but we're also planning for 2025, the long session, to get some additional bills written up and passed by the legislature, bills that would perhaps provide a way to get medications more cheaply, for one. We still have to figure out how to, follow the Oregon Constitution to getting all people in Oregon covered by healthcare. So there's a lot of work to be done.
Okay. There's a pretty heartfelt.
A couple of hands, I think. Mike wants to
you.
chime in, and then Karen on
Thank
that
you.
prior question.
I have my chat open, so I couldn't. It blocks it.
Yep.
So thank you.
So Mike, why don't you go ahead, and then Karen, please.
Yes, for states to create their own universal healthcare systems, it will make it much easier if there is federal legislation that allows them to do that. There are laws in place that restrict our ability. ERISA is one, employee retirement insurance safety, something on that order, that's to protect pensions and so forth. We have to get a waiver for that, and we have to get a waiver for Medicare, which states cannot administer. we need a waiver, and there you all receive a petition in the next month to support a bill in Congress. It's HR 6270 that would, if it were passed, allow states to have much more freedom without a legal challenge to create their own healthcare system. So I'll put that in the chat for you to look at as well.
Karen?
Yeah, I think the other thing that people need to do is communicate with their local legislators, their members of the Oregon House and Senate. We try to do that on a regular basis for the people in our community. And then secondly, our congressional delegation. As Mike indicated, it's imperative that we get people on the federal level to recognize some of the problems that we're facing and try to get some solutions to lower not only the cost of medicine, but also the support for people who want to go into any type of medical profession to not have them come out of school with $300,000 and $400,000 worth of debt.
We're having a little trouble hearing you there, Karen.
Sorry about that. I'll pass.
Okay.
I see Mark's hand. Mark, do you have?
You're muted.
You're muted.
You're muted again. There you go.
Okay. Please consider, right, as Karen was saying, write to our legislators, write to the governor, so that that board doesn't end up being populated by insurance agents. And we should tell her we want a single payer system in Oregon. I think she's very, very hesitant, it appears, and sort of trying to play a middle road. And we need to tell her we are not interested in middle road. We're interested in a change. What anybody can do is join Mid-Valley Healthcare Advocates or Healthcare for All Oregon, which is our statewide organization. They are working very hard, and they have a little more pull than we do just with our local area. Healthcare for All Oregon and Mid-Valley Healthcare Advocates. Finally, I would say there's some real reason to have some hope. No state has ever come this close as we are now to creating a new kind of system of healthcare for its people. No one has ever come this close. We're right on the cusp.
Angel has her hand up. Yeah, Angel has her hand up.
All right, can you hear me?
Mm-hmm.
All right, thank you. I just wanted to make mention, someone was asking what can we do? And I was, there's so many complex issues when we talk about system, right? There's so many different things working together. And so if one part is broken, right? Like that part's connected to something else. So then that part is broken, right? And so it's not like we can't isolate transportation because there's something connected to transportation. So anyway, so I had to focus in on what one thing, right? And I want to focus in on this idea of universal healthcare, right? As I believe that healthcare is a right, that when people get sick, they shouldn't be punished, right? And so the question for me is, why are we so afraid of universal healthcare? We are a society, right, that looks at other places. So let's say California has a bill or California is doing something, right? Or if Corvallis is doing something, the state of Oregon may want to adopt that. We are people who do that. We say, man, this is going really well for them when they do this thing. We should implement that here. With universal healthcare, we see it happening well in other countries, yet we have all of this question, right? All of these questions about there must be a catch. Like we can't afford it. We are one of the richest places, right? Are we still one of the richest countries? I think we still are. Thank you for helping me with that. That's what I was told, y'all, that we were one of the richest countries in the world. But if you look at the health outcomes versus the amount of money that the United States spends in healthcare, it is just mind-boggling. I wish we had the graph. I am so sorry I did not get the graph for y'all. But when I show my students the graph of how much money we spend in our healthcare outcomes, it is with other, right, with other first world countries, it is just so embarrassing, right? And so we have the lowest of those healthcare outcomes, but the most spending, right? And so I say, what is this? Why are we so afraid to do something that has been proven in other places, that goes well with other places? Their problem, of course, now is that they're trying to fill the hospital, right? Because when you actually have good healthcare system, you don't fill your hospitals because people are well. That's what our goal is for people to be well. But if you think about it, right? If you think about that, who loses out if people are well? I don't lose out if people are well. But there are people who lose out if people are well. And so to continue the spiral of healthcare being a privilege and not a right, we have to shine, not shine, we have to cast a darkness over universal healthcare. And I know some of you in this room have heard these kind of suspicions about this universal healthcare without doing the research yourself, without even learning about what is universal healthcare, who uses it in other countries, and what does that look like? And why can't we do the same thing, knowing that we spend so much money, right? Even including our healthcare disparities, we spend so much unnecessary money because of our wrong things that we're doing, that what if we actually use that money that we're wasting on universal healthcare? I don't understand it, y'all. It does not make sense to me. We are always copying, like that's what we do. I say Bruce has got a good idea. I want to use that in my family. That's what we do. We say, you've got the playbook, and I need to borrow that play because it works every time. But with universal healthcare, we have made people suspicious of that. Do your research. And then I want to see y'all write letters. I want to see y'all lobbying. I want to see y'all doing something that's going to push us so that people, at the least, right, we can fix the healthcare system by at least giving people an opportunity to have insurance and not be punished for being sick. All right, I think I'm done now.
I see Fritz's hand.
Great, thanks, Holly. You know, a lot of what people need to fully understand is I equate our current healthcare system to what we currently have as a huge problem in our country, the military-industrial complex. I call it the healthcare industrial complex. You know, when President Eisenhower left office, part of his speech was a warning against the military-industrial complex. And what has been created in this country is the exact same thing in healthcare. So there is so much money. There are so many companies, VCs, for-profit organizations in healthcare that have a lot of money to fight what we're trying to get implemented. So those are the barriers that we have in place. Doug, I hope you don't mind if I quote you. I remember I was on a call with you one time and you made a comment. You said you felt all healthcare should be not-for-profit. My opinion of you after that just shot through the roof. So that was really important to me, and I believe in that very strongly. So the barriers that are in our way for this are huge, and that's why we just can't get it done. That's why it's not easy. Doesn't mean we're not going to stop fighting.
So there is a question for Doug about, given the sale of the Corvallis Clinic to a known bad player in the Medicare market, what can we do to ensure Samaritan stays locally owned and operated for the care for all? That people, you know, so do you have anything to add on that? I mean, that's a common theme tonight because it's so timely. It's in the news. Do you want to add anything, Doug?
Yeah, well, first, Fritz, thanks for that call out. And that's absolutely true. I did say that, and I'll say it tonight. I absolutely believe it. I have a master's degree in healthcare administration and studied healthcare delivery. And I think that a nonprofit, locally driven model is the one that works best, that keeps the community and patients' interests in mind. I just do. All of our board members live here locally, and they're volunteers, and they really care deeply about the communities we serve. And I know the people in our organization do. I think it is different when you have shareholders, right? I mean, you have an obligation to maximize shareholder value, and most of those shareholders probably live nowhere near this area. With the Corvallis Clinic, lots of good people, lots of good doctors over there. We need them in the community. They provide a really important component. I've heard they're struggling financially, but I don't know, all the details of what's going on. I've read what they applied, their application to the Oregon Health Authority, which they have to do to consummate the transaction. So I read that, and it said that they were struggling. So I frankly, I'm a little mixed. If they don't do this, does this mean they go under? And I don't think that would be good for the community. Am I sad and a little bit nervous that they're going to be owned by a company like Optum that is shareholder owned and not locally controlled? Absolutely. So I don't, Holly, I was just kind of speaking on there. Was the question, how do we stop it? Or was it more just kind of my thoughts on it?
Your thoughts on it, and do we need better compensation for Medicare, Medicaid providers? Maybe what can we do to ensure that Samaritan stays locally owned? And then there's other questions that maybe, why did Samaritan buy the Corvallis Clinic?
Well, yeah, Corvallis Clinic made the choice that they felt was best for them, and I don't know. I wasn't in the room. I don't know all those details. Like I said, I respect a lot of people over there. I do think Medicare and Medicaid payments are too low. I think that is one of the fundamental struggles that we have in especially more rural Oregon. 75% of our business at Samaritan, our patients come with Medicare and Medicaid insurance. That's a really high level of governmental insurance. If you compare Samaritan to like a healthcare system in Seattle or some of the bigger cities where they have a lot more commercial payer, commercial insurance, which is higher reimbursement. It's higher reimbursement, but it's more complex. We all know that. Those are the benefits of single payer, is that you're not dealing with the complexity of all these different insurance companies. So I mean, that plays into it as well. But I do think Medicaid and Medicare is too low. And I do think I had watched some of the chat, and I think it's Leah Stenson from Hood River, which I don't know her, but I think we are like kindred spirits. Some of her comments about, I think we need to move from a kind of a fee-for-service model to more of a population health-based reimbursement model, I think is spot on. I think Bruce talked about moral injury, spot on. And I'll say part of the moral injury that I think we have in healthcare is right now, we know under the current model, Samaritan will make more money the sicker our communities are. I think that's an absolute misalignment of incentives. I think it's a tragedy. I think organizations should be incentivized to make communities healthier, not get them unhealthy and they get paid more money than you're taking care of them when they're sick. I think that's just a misalignment. So I think we need more of a population health reimbursement model. And I absolutely believe that all healthcare is local. I think Leah made that point as well. I do get a little nervous when people talk about Medicare for all, because that comes out of Baltimore, and that's a very kind of rigid system. I love our CCO model that we have for Medicaid here in Oregon that pushes the resources to the 15 regional CCOs for healthcare and food banks and housing organizations. They can all work together to figure out how we can help with community health. And I think that's how we have to think about it going forward.
Thank you. I've missed a few hands that have been up because my chat window, but I see Bruce. Can you go ahead? Sorry, apologize. I also saw Bobby and then Eddie Koenig.
Edie Koenig.
Edie, we'll go in that order. Thank you.
Yeah, I was just wanting to get back to a lot of what Angel was talking about healthcare as being a right. There are, so many high-income countries in the European Union that have figured this out. In Germany, there are private healthcare insurance companies. It's just that what the Germans have done is that they made excess profits illegal. So you can't make excess profits on healthcare. And that helps to fund, that way more money stays into the system of funding healthcare for all. They've had healthcare for all since the 1890s.
Thank you. Bobby? Is she unmuted, Fritz?
No, I'm not muted now.
Okay, thank you.
I lived in Canada for 4 years, 1970 to 74. We had universal health care. It didn't cover dental and a few other things that we would like, and that our system that was worked out for us would cover, but it was excellent. We lived there for 4 years. I had a hospitalization. No questions asked. I was out of town. I needed it. I was taken care of at once. And darn it, that was 1970. For God's sakes, what is the matter with this country? I just don't know. My goodness, every year things have gotten harder for anyone who wants to be covered with health care. That's all I have to say. I also taught at OSU, and I taught about health. Yes, I taught about health, and I taught about universal health care every term. Thank you.
Thank you. So Edie. We may have to unmute on our end.
And unmute. There I go.
Okay, thank
the
you.
only reason I raised my hand was to be sure that you saw Bobby's.
Okay. Okay. Also, you had a comment you had a question and here more of a story. I think earlier in the chat. I was going to go back and see if we could. It's about the mental health issues that we have.
Oh yeah.
Lack of care for that. So
Yeah.
was going to throw that out to our presenters about.
I do not know what this state could do, but this state is desperately in need of residential health care.
Yes.
And my daughter finally decided that she was not ever going to get help from the hospitals. And so my husband and I simply monitor her constantly. We lock her walker up at night. That's another question. We hide her shoes because she has the idea she's going to jump off a bridge. She's afraid to start driving again for fear that she will wreck the car by hitting a telephone pole on purpose. This state desperately needs mental health care. I don't know if it's a matter of paying for mental health workers to go to school or what it's going to be. But it's a pretty bad situation to be in.
Doug, I see your hand up.
Yeah, just a comment off that, Edie. I read your story, and I think our mental health system in the state of Oregon is absolutely broken. Our state hospital referrals up to that hospital. Really, you can only refer patients to the hospital now if there's mental health issues and there's been a crime that's been committed. And they used to take a lot of the high acuity patients that needed psychiatric care. But now it's so hard to refer patients there that folks are getting stuck in local hospitals like Samaritan across the state. We do have an inpatient unit for adults, not for adolescents, but we're just not equipped for the acuity we're seeing. And we need the state hospital to take more patients. The county health departments, I think, are great people doing a great job. I think everybody's just overwhelmed right now. We need a better state system to address what's going on with behavioral health, mental health issues, because it's a growing concern of mine.
That inpatient unit of yours, Doug, if it's the one I'm thinking of, my daughter did receive some help there. Unfortunately, could only stay 10 days, which is more than anybody else has had her. But the last time when she needed them, unfortunately, they said that they had too many violent people in there at that time, and that would not help her. And there's perhaps a necessity for a second one for nonviolent people, and a larger one at that.
Yeah, I apologize for that. And that is true. There are times where it's actually dangerous for us to bring other patients into that facility. We're just seeing such high acuity. And I think you made the comment earlier, we needed more residential centers, and I absolutely agree with that. The other thing we need in the state are more addiction treatment centers, substance use disorder treatments. I think the last data I saw that Oregon has for our population, one of the highest rates of addiction for substance use disorders. And we have one of the, for a population our size, the least amount of facilities to serve those patients, unfortunately.
Mike has his hand up. Go ahead.
Yeah, before we close, I just wanted you to please tell your friends who couldn't log on that we apologize for this limit that was unexpected. We paid for the expansion to 500 capacity. Zoom allowed 365 people to register. That would imply that they were going to allow up to 500, but they did not. And I'm pretty upset, as you can imagine. But we will send the recording to everybody. So look for that in the next day or two.
Okay. There is one last question that is asking for Doug and the others to address. It's just the problem is not providers, it's how we pay for it. Besides no profit, the second principle of systems that work in other countries is they have a single payer, setting the payment the same for all treatments in medicine, and healthcare providers competing for patients by the quality of patient experience. They just asking for Doug and others to speak to that idea. Any, Bruce, your hand.
Yeah, so the Oregon legislature did a study in 2016, I think, using the Rand Corporation. And the question was, how much money is needed to cover all Oregonians with a universal health care plan. And the short story is that the Rand Corporation estimated that there's already enough money in the current healthcare system to pay for healthcare for all Oregonians. Now, that was in 2016. I don't know if that's still the case, but that was the case in 2016.
Okay.
Well, Holly, I'll just say quickly on that. So I don't disagree that single payer would simplify things. I think that's definitely a viable option. I think what I often say, though, I'll go back to something I said before. I often think more about what's more important is how we get paid rather than who's paying us. And I think if we're going to go single payer, we also have to fundamentally shift how we pay for it. We have more focus on population health. So I just would add that as well.
Would a global budget be something that would help describe what you're talking about, Doug?
Yeah, I think so, because then it's not just all based on productivity and the doctors are on a hamster wheel. I think if it was more of a global budget, then we could think proactively and be a little bit creative about providing those high value services that keep people healthier in the first place.
Thanks
And
for,
we agree.
Bruce, do you have any
Encourage-
final
Oh, sorry.
comment?
Sorry, I just wanted to add that I encourage everyone to look through the chat because Mike has placed some links in there, some very important links. A lot of other statements were made by people attending that are very good. Some of the presenters have answered questions on the chat. So I think that I just encourage everyone before you log off to look at the chat.
And Holly, can you tell people how to preserve the chat so they can look at it after Mike closes the meeting?
Okay, I'm actually not sure I know how to do that. Sorry, showing my, how do you preserve this chat? Let me see. I think I can.
I know that's beyond my competence.
It is. I don't really think you can.
Yeah, if you, Holly, this is
Go
Linda.
ahead.
If you go in the meeting chat box, when you open up if you go down to the bottom, chat, meeting, from the left-hand side, three box that say more. If you on that, it's a save chat option.
We're not hearing you well, Linda.
Yeah, unfortunately, Linda's kind of freezing up. So it's the bottom of the chat box. There's the three dots. Click on the three dots. A menu comes up. And at the very top of the menu, it should say Save Chat. You click on Save Chat. And then next to that in the chat, it'll say Show in Folder. And it will have dumped it on some folder on your computer. Usually goes into Documents, then a subfolder Zoom, and then it'll have the title and the name of the chat.
Zoom folder. I took it.
Okay.
Thank you for that. Angel, any last comments from you?
My last comment would always be, I'm just thinking about how hopeless I would feel many times working at bedside, right? And realizing now that there is always something we can do, right? And so I just really want people to take a moment to, I don't know, just figure out what does that look like for them, because we all have a part to play. We all have a role to play in changing things, and things, sometimes things are, this is a mountain, right? This is a huge mountain and it's been broken forever. And so sometimes it's easy for us to lose hope and think we can't do anything, right? And then there's some of us in the room, like Mike, who's been fighting for many years. And I told him that the fact that he never gives up makes a difference. And so I just want us to remember that we can make a difference. And if it's not for us, it's for our children and our grandchildren, if that makes sense. So even if it didn't happen in my lifetime, I'm fighting so that my kids and my grandkids would reap those benefits. And one more thing, I'm thinking about the people who fought so that I have what I have, right? And so I just don't want people to look at this and think, man, there's nothing we can do, because that is a lie. And I think that's what the powers that be would want us to think, is there nothing we can do. So thank you all for being here. I really appreciate it. And I look forward to more of these, not only conversations, but action, things that we can do together.
Great. Holly lost connectivity. So I'm going to, Doug, last comments.
Yeah, I appreciated Angel's comments there. I think this is a daunting, complex problem. Otherwise, it would have been solved a long time ago, right? But I think we need to get through the complexity of it, and we need to seek alignment. And I know that's way oversimplifies it, but I think the more that we can have these conversations and really start to, it's a very abstract, complex issue, the more that we can work as a group to talk through it and get alignment on the issue, then I think the voters can push forward ideas that can be passed. I think right now it's so complex that we all get pulled in a lot of different little nuances and we never get anything done. So I think we got to figure out how we come together and work together. And it's going to take a while and it is complex, but I do think that there's a better day out there for healthcare.
Great. Bruce, and then Karen close us out.
Yeah, so I think in my opinion, the complexity of the current system is what is driving clinics like the Corvallis Clinic to the point of financial distress, which then allows consolidation with a for-profit, private equity, shareholder-driven corporation to move in and take that local control away from the local community. So it is the complexity that actually, has been built into the system, which is perpetuating the system.
Thanks, Bruce. This has been an incredible evening. On behalf of the sponsoring organizations, I want to thank our speakers. You've all just been really wonderful in sharing your perspective. Fritz has put a survey link in the chat. So it asks if you could take a few minutes and do the survey. Please continue to learn more about our healthcare system and the challenges we face by participating in the programs of our co-sponsors: Mid-Valley Healthcare Advocates, Healthcare for All Oregon, League of Women Voters of Corvallis, Lynn Benton NAACP, and the Lynn Benton Health Equity Alliance. All have committees dedicated to working to improve our healthcare system. Thank you all for attending tonight, and we hope we see you at our next program in the coming months. Thank you.